primary infection and secondary infection. In dengue, people can have recurrent dengue and repeated dengue. They can be infected second time, third time. At that point of time, because of the anamnestic response, which is a memory to the previous infection, there will be a sudden rise in IgG from the very beginning itself. So somebody is having an NS1 antigen positive with rise in IgG without IgM being positive, then probably you consider it as secondary dengue. So if you are seeing a patient with dengue, the first thing is early days you order only for NS1 antigen. Please do not get an IgM and IgG done in less than 1 week, which leads to confusion or probably may not get a proper result. Now, when it comes to dengue, I would like to highlight 3 very important points which are considered to be the severe dengue scenario. So, yes. So you will have so many warning signs like abdominal pain, persistent vomiting, mucosal bleeds, lethargy, and then if you can examine the abdomen, you might have liver enlargement, and laboratory you will have increased hematocrit. But the main 3 points which you need to understand whenever you are seeing a patient is, one is the hematocrit, where that leads to severe plasma leakage, and then that it is a sign that tells us the patient is going into a probable dengue shock. Then the other one is the bleeding, which is quite evident to you. Then the third one is organ involvement, which is very clearly evident through elevation of liver enzymes, SGOT and SGPT. So we have a small charting in our hospital cell checking only these 3 points. We have only every patient admitted with dengue, we put hematocrit, liver enzymes and APTT as an indicator to identify which patient is going to us. And if somebody starts, when we go to the hospital and when during the roads, if somebody starts saying that, sir, today platelet count is 30,000, we immediately tell them, go and write the other 300 times. Write hematocrit, write SGOT, SGPT and the APTT 100 times. Because we know that platelet count is not important. What is important is the organ damage or the vascular leak. So considering these factors, I would like to recommend, remember 3 main factors, hematocrit, liver enzymes and the activated partial thromboplastin, which can be useful in identifying the sick patient. So the other thing which I wanted, because as I said, platelet transfusions are not important, you need to remember prophylactic platelet transfusions are more dangerous, to be frank. The reasons are umpteen, and probably they are more often though they are at a research level, it is very clearly proven that prophylactic platelet transfusions can lead to further coagulation abnormalities, and that can lead to further worsening of the patient. So, if somebody asks you, at what time would you like to give platelet transfusion, it is advisable to say, no, I would never give platelet transfusion. So, it's not at 80,000, it is not at 40,000, it is not at 20,000, even if it is not at less than 10,000, unless there is a bleeding. And the preferable one is not actually the platelets, it's actually either the blood transfusion if someone is bleeding, or if you would like to give specifically platelet transfusions, it would be along with fresh frozen plasma. So that's the case 1. So, case 2. A 40-year-old male complains of fever, nausea, vomiting since 1 week. Similar febrile illness twice in the last 1 month, lasted for 5 to 7 days, subsided with antibiotics. Quickly, what would you like to think? There are no other symptoms in the patient. Again the same. Viral cannot be happening again and again. Malaria, one possibility. I actually to leave the flu, I just left only fever without chills. Yes, left with entry. So, what should be the investigation of choice in entry fever? The reason why I included this slide is because out of 10 patients coming to the hospital, 9 of them on day 2 or day 3 are still having a Vidal test in their reports. So, many of us, blood culture is the investigation of choice, but still why Vidal? So I took this small
few tens of people sitting here. At least, if all of us sitting here would stop advising or asking for a test called Vidal, I think that makes a difference for this conference on day one. It would be the first session. That's a big problem, sir, because I think we are going deviating from the point. But there is a patient who comes with a respiratory illness, being done a viral test, informed as typhoid and being treated as enteric fever, could be having some other illness which is progressive. So it is advisable not to do this test, especially in an area where there is endemicity, which the points have already been mentioned. If you want to know, probably all of these are well known to us, but still in India, this test is being used rapidly and being told, because once we start using them, we invariably know, we see 10 patients, there are registered medical practitioners so-called who use it in hundreds of patients, and then the diagnosis goes its own way, reasons which I need not tell. The other test which is being commonly used nowadays is typhoid. Again, this test is also an issue because of the background antibodies in general population cross-reactivity with many antigens, suggesting low sensitivity and specificity. Both these tests, Vidal or typhoid. Instead of that, your clinical experience will definitely be, as I said, it's an acute undifferentiated febrile illness. I just gave 2 lines. Many of you told that's an enteric fever. So, would love to have our experience being top of these investigations or go with the standard test, blood culture. Coming back to blood culture, I would like to add a point here. Still many of us are very, not reluctant, still we find it difficult to send a blood culture. Of course, definitely it's not that easy when compared to the other regular investigations with a simple technician available under our hand. But these days, blood culture centers have increased, collection points have increased. So blood culture is always a good option, not only for the enteric fever, but many situations where now we are seeing multi-drug resistance. So it is not that difficult, because now I thought there is a training program happening after these workshops on ECG and I think emergencies. There should have been a small workshop added on blood cultures, how to collect a blood culture, how to help the technician to do it in a proper way. Would have definitely made a difference. I think down the line would be a good choice also. So blood culture is the gold standard which everyone of us know, and if you have a suspicion, if a patient is having enteric fever and if you are doing it on time, even after first week also, there is high possibility the culture comes positive and we are seeing good number of patients. So what is your choice? Because now we moved from diagnosis to ceftriaxone. Okay, good. What about trimethoprim sulfonic oxazole? Okay, what about ciprofloxacin? Yes. So there is growing resistance. Definitely, ceftriaxone is the choice, but there is good amount of evidence now that trimethoprim sulfonic oxazole is sensitive. So either of those drugs are good. Quinolones, there is significant resistance, and of late we are hearing resistance to cephalosporins as well with respect to enteric fever. So that is the reason why I am saying blood culture is very important. The next thing is how long. I'm sorry, I should. How long do you want to give the treatment? Yeah, how long will the fever be there? The biggest problem in typhoid, what we observe is the fever doesn't subside until 5 to 7 days. So that is the reason why enteric fever is still a confusion, a menace in this country. On one side, a Vidal test is a menace because you do not really understand whether the test is right or wrong. On the other side, when we start treating, it takes time for the fever to come down. So for 4 to 5 days, the fever doesn't come down and you are suspecting enteric fever and you do not have a clear-cut evidence that it is an enteric fever. You are doubtful about your diagnosis and you want to change your diagnosis. So that is the reason why please push towards blood culture, which will definitely will add value at least in 50% of your patients when you do not have the diagnosis of enteric fever or suspected diagnosis of enteric fever. Because we are still not seeing many people being sent for blood culture when you suspect enteric fever. That is the only way which can substantiate your diagnosis, and you need to wait until at least 10 days. So this is the last case. So 35-year-old female, fever, high grade, continuous, cough 4 days. This is common. You come across every time. on antibiotics was given outside, amoxicillin clavulanate, then ceftriaxone, then piperacillin given antimalarials, whatnot, everything. This is the commonest case which we come across, right? You get a patient with 10 days fever, this is the commonest case. So what happened to this patient? I'll give you more details. Now you can see there is some WB, high WBC count with some thrombocytopenia here with normal differential count, right? I'll give you some more details. There is some elevated bilirubin with SGO, SGPT, RMP is slightly abnormal, chest X-ray ultrasound echo all normal, 2+ proteinuria in urine. Now, okay, let me give you the possible likely diagnosis. What would you consider? 10 days. So something like viral or 10 days lasting such long fevers, taking is out. Fantastic. So you know the answer. So the rickettsial infection, this is the case. So where is the start? So just don't forget. So in your febrile illness form, when you put acute undifferentiated febrile illness, there should be one very important note that should be made. Check for skin and soft tissue changes, which probably I think very speaking something different. The first topic earlier was different, systemic manifestations of skin disorders, but I think now it's changed to drug reactions. We were waiting for that. But anyway, always do not forget when you are checking a febrile illness patient, please check completely the whole. This is always told by our seniors, but we forget. But at least now, for the reason of scrub typhus, we are forced to check. There are so many areas where probably they are not easily picked. And the people will say, when we say that, why did you tell this? We thought this is a normal thing. We did not tell you. So doxycycline is the drug of choice and azithromycin and rifampicin are the alternatives. The last one, and my favorite one, I have 3 minutes time probably. 45-year-old male patient, diabetic, obese, and present with PRH, fever and diabetes. So he was being seen for recurrent lower urinary tract symptoms since few weeks. His pressures are 90/70, 120 per minute is the pulse rate, 20 per minute is the respiratory rate, and 95% on road rate is 244 milligrams per deciliter. Now, I told you, in the beginning I told you, you have a 2 days history, a patient coming to you, you have enough time, don't worry about the diagnosis, take your time. Wait until day 3, day 4. You can then send for basic investigations like qBCMP and then NS1 antigen. Wait until day 5, day 6, where probably you can send for blood cultures and rest all investigations. Now this is a situation where you cannot wait until this because you